Good evening. We'll be talking about peripartum cardiomyopathy today. So, as the name implies, cardiomyopathy means the muscle of the heart is damaged. So, basically, there is a structural or a functional abnormality in the myocardium, but there is an absence of coronary artery disease, hypertension, valvular heart diseases, or congenital heart diseases to start the issue, right? So, that is what cardiomyopathy is. It's a structural and functional deformity of the myocardium in the absence of a known disease. So in 2008, the American Heart Association gave a classification of cardiomyopathy as primary and secondary cardiomyopathies, in which primary cardiomyopathies are the ones which are confined to the heart muscle, whereas secondary cardiomyopathies are the ones which are basically there is a other systemic disorder, and secondarily that affects the heart and leads to cardiomyopathy. So, out of which peripartum cardiomyopathy is a primary cardiomyopathy, but it's an acquired type of a cardiomyopathy. Although there are some genetic factors which are responsible for it, it is implicated that genetic pathophysiology is also there, but it is termed as an acquired form of primary cardiomyopathy. So initially in the 19th century, peripartum cardiomyopathy was not really called as peripartum cardiomyopathy. It was referred to as postpartum cardiomyopathy because most of the cases of cardiomyopathy were diagnosed before the delivery of the child. But then later on, in 1970, that is in the 20th century, Demakis and Rahimtullah were the first ones to recognize it as a peripartum form and not a postpartum form. So they describe peripartum cardiomyopathy as a development of idiopathic, life-threatening cardiomyopathy, which begins in the last month of pregnancy or within the first 5 months of postpartum. And most importantly, it occurs in patients without any pre-existing heart disease. So a woman already having an existing cardiomyopathy has some exacerbation during the pregnancy, we won't call it as peripartum cardiomyopathy. A woman who's completely free of any cardiac issues develops a structural and functional abnormality of the myocardium in the third trimester, specifically in the last month or in the months following delivery, is actually called as peripartum cardiomyopathy. However, this definition by Demakis and Rahimtullah was then modified by Heart Failure Association of European Society of Cardiology, which was called as a working definition. And what they did was they said that peripartum cardiomyopathy is a systolic heart failure which manifests towards the end of pregnancy. So what Demakis and Rahimtullah had described they had described it as development of peripartum cardiomyopathy in the last month of pregnancy and the first 5 months following the delivery. But then this definition was changed as towards the end of pregnancy. So the duration, the exact point was removed. So manifesting towards the end of pregnancy or in the months following delivery, for which no other cause is found. And also echocardiographic criteria were also included in the diagnosis of peripartum cardiomyopathy, which said that if the ejection fraction is less than 45% or fractional shortening on M mode is less than 30% or both, and LV may or may not be dilated, because in the initial stages the LV hypertrophies, but then later on it starts to dilate. So most importantly in this working definition, the time frame was removed, and secondly the echocardiographic parameters were also added. So either EF less than 45% or fractional shortening. It is a parameter which is measured on M mode in short axis of the left ventricle, in which we measure the left ventricular internal diameters in diastole and systole, and accordingly we calculate the fractional shortening. So if the fractional shortening was less than 30% or EF less than 45% or both, so they contributed to the diagnosis of peripartum cardiomyopathy. Now, why third trimester? It could have just developed in any trimester. So basically, third trimester, it involves a lot of hemodynamic stress, and there are high levels of estrogen, progesterone, and prolactin, which are actually known to decrease the contractility of the heart. So that is why the chances of peripartum cardiomyopathy are very high in the third trimester, not before that. One more question, or just for your knowledge, a cardiac disease that specifically presence in the second trimester of the pregnancy is obviously mitral stenosis. So anything, if a pregnant patient starts developing dyspnea on exertion or some cardiac signs during her second trimester, so that should give you an idea that probably an underlying mitral stenosis could be there. But if specifically in the third trimester, if she presents with all these signs and symptoms, then the diagnosis of peripartum cardiomyopathy is quite likely. So incidence, it's quite a rare phenomenon. It occurs in less than 0.1% of pregnancies, and higher incidence is found amongst African American women. And probably the reasons are that they are more predisposed for preeclampsia, eclampsia, and also there is high chances of selenium deficiency in these patients and other genetic abnormalities also, which increases the propensity of peripartum cardiomyopathy in these women. So overall, what are the risk factors for the development of peripartum cardiomyopathy? So generally, multiparity, advanced maternal age, multifetal pregnancies, preeclampsia, HELP syndrome, hypertension, diabetes, smoking, prolonged use of tocolytics, obesity, cocaine use, and also family history of dilated cardiomyopathy. Remember, peripartum cardiomyopathy is a form of dilated cardiomyopathy only. So the patient with peripartum cardiomyopathy will present like a dilated cardiomyopathy patient. So now, what is the etiology of peripartum cardiomyopathy? So there are several theories which are proposed, out of which the most important one is the oxidative stress. So what happens is that deletion of STAT3 protein, which is a signal transducer and activator of transcription 3. So basically, STAT3 is responsible for the scavenging of reactive oxygen species. So deletion of STAT3, in the presence of deletion of STAT3, if there is an oxidative stress, that triggers the cardiomyocytes to express cathepsin D. So this cathepsin D, it causes conversion of prolactin into 16 kDa derivative. And this 16 kDa derivative is pro-apoptotic. It induces cell apoptosis. It is anti-angiogenic, and that finally causes cardiac injury. So this is the first mechanism that probably leads to peripartum cardiomyopathy, that is oxidative stress because of the deletion of STAT3. The second proposed mechanism is autoimmunity, because there is a natural immunosuppression during pregnancy. So if fetal cells, whenever they escape into the maternal circulation, they don't get rejected, and these fetal cells selectively concentrate on the sites of maternal cardiac cells, and they finally result in autoimmune myocarditis. The third mechanism is inflammation, because pregnancy is a pro-inflammatory state. Because in peripartum cardiomyopathy, the blood levels actually showed a high levels of pro-inflammatory cytokines. So inflammation is one proposed mechanism for peripartum cardiomyopathy. Fourth one is viral myocarditis, because pregnancy is a pro-inflammatory state. Pregnancy has a natural immunosuppression. They have decreased natural killer cells. So that is why viral cardiomyopathy is myocarditis is very common in these patients, and that could be one of the predisposing factors of peripartum cardiomyopathy, because patients with peripartum cardiomyopathy were found to have Epstein-Barr virus or cytomegalovirus, herpes simplex virus in their blood. The genomes were found. Another mechanism is genetic predisposition also, because mutations in TTN gene, which is responsible for the formation of titin, and mutations in LMNA gene, which forms lamin. So both of them are responsible for the proper structure and function of the cardiac muscle cells. So obviously these are the proposed mechanisms for peripartum cardiomyopathy. Now, what is going to happen? What is the pathophysiology of peripartum cardiomyopathy? So this patient will present like a heart failure patient, obviously. So if it's a left-sided heart failure, we have already discussed in our previous sessions that whenever there is a systolic dysfunction, the filling pressures inside the left ventricle increase. As the filling pressures go high, that means the left ventricular end diastolic pressures go high. So in that case, now the left atrium has to generate more pressures in order to empty the blood into the LV, because during diastole, the pressures of the LV are high, which are not normally high. But now, as they are high, the left atrium is supposed to generate more pressure in order to empty itself into the LV. So this increased pressure of the left atrium that gets transmitted to the pulmonary circulation, that causes increased pulmonary pressures, and that causes pulmonary congestion. Moreover, there is a left-sided heart failure, so obviously the perfusion, the forward flow is also going to be affected, because the LV systolic function is getting compromised. So obviously in left-sided heart failure, the systolic function being compromised, the forward flow is going to be compromised, and because of increased backward flow, the patient is going to have the respective signs and symptoms. As far as the right-sided heart failure is concerned, same, the patient will have an increased right ventricular end diastolic pressures, because of which the right atrial pressures will increase in order to empty the blood volume from the right atrium to the right ventricle. That's why these increased right atrial pressures will be transmitted to the systemic circulation, leading to systemic congestion.